And thank you for the introduction. I'm from Franklin Memorial Hospital, and we're in western central Maine, and we're a small community hospital. We use about 50 beds. We're, I think, licensed for 65, but we also have 14 office practices. So that's where I'm coming from with this presentation. This is our coverage area. We cover about 1,000 square miles, but it's only 29,000 in population. We're not a very diverse community. We have about 2% minority in the whole state of Maine, but we do have a lot of low socioeconomic people with low socioeconomic status. In general, we have 6 members on our health literacy steering committee that are very consistent. We have occupational therapy, social workers, behavioral health, healthy community coalition. We have a physician assistant, and once in a while we have a physician. We also have nursing, but we also have some members that are floating members. We lab, billing, people from radiology, from facilities, maintenance, depending on what project we're working on. These are just some general areas that we focused on, generally awareness, environment and navigation, patient education. We have developed a literacy volunteer program, and of course teach back education and documentation, which I'll talk about a little bit. Looking at the attributes, I found that we actually have covered most of them. So I'll address how we went about doing that. We had great leadership support. I'm the director of our education department. They have no idea what I'm supposed to do, so they gave me pretty much full reign in that. Plus, it impacts their bottom line. Anything we can do to help prevent readmissions will certainly affect their the money that they are generated and don't have to pay out of pocket. Our avatar scores are also where we're getting graded on patient satisfaction, and if you know anything about leapfrog or how hospitals are competitive against each other and insurance companies want to send their patients to the best hospitals, Maine happens to be some of the highest rated hospitals in the nation, so we're competing against a high-level group. So those are also very important. So we can get our patients satisfied, then our scores go up. So leadership was right on board with anything that we do with health literacy. We did an organizational assessment, and I found that only 15% of our clinical people did anything with teach back initially. That was really sad. Now we're up to about 66 to 89%, with the best being in OB and physical rehabilitation, because it's pretty well built in to their system. And we are working on that on a daily basis. We prepare the workforce by teaching awareness and education about health literacy and how it impacts our patients, also our bottom line, our jobs, anything I can push in there for them to adopt it. We've utilized lots of different health literacy strategies. Many of them are online, the Universal Precautions Toolkit, all of the wonderful resources that are out there that are free. And we are concentrating on safety and also our core measures. Safety a lot with patient medication is very important. Some of the other accomplishments we had a policy in place for patient education, which we have redone 3 times based on what we have learned, and that's revised every 3 years. So that keeps our patient education and health literacy going. Our population needs are vast. We have a very large volunteer population in our community. They're mostly elderly, and we have a system where they can pay off their medical bill if they actually volunteer. They can also bank hours, which goes towards any future medical bill for themselves or their family. So our volunteer workforce is almost equal to our actual employed workforce. But they're very, very useful to use for any testing any materials out, so we take advantage of that. We've also incorporated our chaplains into our program, since they work, like sort of boots on the ground, right, with all the patients. And we have a large mental health population because we have a behavioral health services. We're sort of the only show in town, so we have to cover all disciplines. And we've been able to include them in focus groups for testing materials. Our high-risk topics that we've chosen: congestive heart failure, particularly because of the readmission penalty that we get if they're readmitted within 30 days. Medications such as anticoagulants, diabetes, any different procedures that we do. So we've really addressed all of those areas. We've tried to find as many in-print programs that we could already, but many times we've had to design and develop our own. So we've been learning more about plain language and teaching others in different departments to know how to write that letter to their patients on how to access their phone line or about their bill. We've done a lot of user testing, but that is still an area that we really need to continue with. Billing is one of the areas that we're dinged on all the time for patient satisfaction. I don't know if people don't like to pay their bill, but honestly, I can't understand the bill either. So we're working right now on how to format the bill and explain to patients how they need to pay and what Medicare covers. We have a lawyer in our group who, my son's in law school, so I have nothing against lawyers, but she thinks that she knows plain language and does plain language, but with consent forms and everything, it's been a real barrier on thinking that this is the way it has to be. And I love Bridget's HIPAA form. I think that was wonderful. We also included a lot with navigation in that book on environment of care, and you're navigating the environment, having a lot of people just plain old getting lost in our system. We found our signs where we did secret shoppers. We found our signage was not consistent. So radiology, if one needed to go to x-ray, you had to know either radiology, CT scan, or x-ray, because they had all those three different signs. And if you followed one sign, then you couldn't find which way else to go. We had no icons in our facility either, so not even know where the cafeteria was. So consistent signage. So what we had done was an awareness campaign, patient education, a lot of patient education. We did a library on wheels carts because we didn't have resources on the floors or in our office practices, which are attached to our facility. So we have a portable cart, and we have 8 of them now, with a computer on it. We can show patients how to surf the internet and which areas they could look up anything on medical advice they wanted to later on after they were discharged, and something that was real valid and reliable sources. And they also allows the nurses or the CNAs to start a DVD on patient education materials that they needed. So those are some of the things that we did. I put a lot of things on the slides just for future reference. Of course, we did teach back and a lot of education and evaluation of like our videos, needs assessments. We found we did we were good at doing knowledge, telling them like what your Lasix, your medication is for. Not great on attitude, like why is it important. And skills we did okay if we had to teach them, but not the skill of how are you going to remember to weigh yourself every day. So we've been using the Ask Me 3 program. Ask would be attitude, skills, and knowledge. And that's what the nurses remember, and it's just been so easy for them to continue teaching. And I had mentioned the environment navigation, which included the icons of fonts, words, everything that you would incorporate with health literacy. Using the patient tracer methodology from Joint Commission, since we are Joint Commission certified, and we looked at what happens with a patient when they actually arrive on our campus. Do they know where to park? We have elderly patients walking all over our large campus, getting lost and tired and not knowing where to go. So we worked on signage and followed it right from the entrance to our hospital all the way through to the office practice and discharge billing. So we looked at every single area the patient might be going to. We have done quite a lot of work with our lab, because doing our education programs, we found that they were getting a lot of recalls and refusals of samples. And it happened that the office practices weren't giving them the right information. So really following through on different departments' issues. And all of these came out of teaching over 400 people in our organization about health literacy. We also found a great book from the University of North Carolina on congestive heart failure that we've been using and adopted, only the nurses thought they had to give it to them every single time, and it's a book, so what do people do with that? They look at it once, it's a reference. We decided that with permission from the author, we took the pictures out of that book and made a one-page plan, which I found out that one of the physicians actually used for a research project he did. So this has worked extremely well. To make things on one page, as Bridget had mentioned, is the most important thing that I think we have done. So we use that with the pictures, with some words, and what to do if they're in a certain zone. We also work with mental health. This is one of our focus group things. We're trying to decrease the ER admissions with our mental health patients because they can get help earlier than that. So we put this together with their assistance, with their families and the the mental health, the people with mental health issues. So that has worked as well. Our interest was generated. I've always been passionate about about health literacy and education. Our audits generated interest. Anything that we found was a problem: missed appointments, non-compliance, readmissions, repeat labs, our issues with our learning management system. All of those things were important to continue on. We shared our observation that they flunked, health literacy and teach back, so they're a little bit competitive, so they've done a good job. Our Avatar scores with our patient satisfaction. So we looked at all of these different areas, taking a team approach, integrating it with a program of customer service that we were already doing really helped out an awful lot. Anytime we could piggyback on any other project going on, we did. We also incorporated our clinical documentation, our IT integration for documentation and making it hardwired into that system. Some of these things I've already spoken of. Have support of our legislators to continue on with patient ed, looking at our Medicaid population, who we have 41% smoke who are Medicaid patients, whereas 19% of the other population don't, smoke. So why is that? I think it has to do with their literacy level, but trying to sell that still. The physicians are also being graded by patient satisfaction, which is a CG CAPS, now that they're getting one-on-one grading on how effectively did you communicate with your patient. That is helping to get them better engaged. We're looking at more leadership engagement, continuing on with our interdisciplinary team, collaborating with the Geriatric Education Center at UNE with 4 other teams in the state and sharing ideas, and looking at combining it with other initiatives. Our barriers, our providers have said, well, we don't do teaching. Our MAs do the teaching. I said, well, what about, consents that you get from your patients? And we're still trying. Some of them are very good and are right on board with patient education and health literacy. Some of them are not. So we're still working on that. Marketing has also been a barrier. She attended a 1-week-long program on health literacy and now is an expert and still keeps doing fancy fonts and shadowing and ghosting and everything that makes it much more difficult to read. So I'm still trying to work with her. We have a 1-team marketing department. And same with our lawyer with consents. There are not as many pre-made materials. And of course, some of the nurses say we have no time to teach. I hear that all the time. But you have to find that Kodak moment of teaching. As a nurse, you always teach. They don't know what Kodak means because they're digital. Trust is always something that we build up with our patients and our staff, and I think we've done a good job of that. But we also have an issue with our employees. People who work in the kitchen and maintenance, our people in the laundry. Many of them are health illiterate, and we've been trying to work with them as far as bringing them up in our learning management system, making it in plain language of the information they have to do all the time. We've integrated it into our orientation program, so every new employee has a program on health literacy, hardwired it into our electronic records for teach back, for assessment, on do they have difficulty filling out forms. We have developed a reading coach program with our volunteers. They were trained by the literacy volunteers of our county, and they are right in our hospital volunteering as reading coaches to help people with their forms and to refer them to literacy volunteers if necessary. We've also been working with our community dental and other practices in our community. Since we share all the same patients, it's a revolving door, so we might as well include our nursing homes and everyone else in our whole entire community. We have been training training others for plain language in all of our departments. And our policies are needing to be up to date every 3 years, so that keeps us on our toes and reviewing our information. We do have some financial support for patient ed materials. We're very fortunate that our Odd Fellows group in town have donated money specifically for patient education, since they are actually recipients of it, since their average age is 84. And we're very dedicated to doing this, and we have a really good team. So community education. We've really affected a culture team. I've been doing this probably for 6 years now, and Our nurses are even saying in MAs, we even use teach back between ourselves for our handoff communication. So I was like, whoa, they understand teach back, and they're actually putting it into practice between themselves. We have a learning management system of our clinic, everyone has to take, fire safety and all that. We're trying to make that into plain language as best as we can. Accreditation requirements, make it sustained, and our hospital rating needs. So there's a lot of support with having to do core measures constantly. All the rules are changing for Medicare and Medicaid, so we might as well jump on board, and if it's something that's important to the hospital, we do health literacy in plain language with that. And that's a view from my porch.